Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James and today I'm delighted to be joined by Paul Silverston. Welcome to the show, Paul.
Well, thank you very much for the invitation. Very much appreciated. Great honour. My name's Paul Silverston and I'm a visiting professor at Anglia Ruskin University and visiting professor of primary care at the University of Suffolk. So it's a great pleasure to be invited to be with you today.
I think it's fair to say you have a sort of slightly unique history with the physician associate profession, and I thought it would make a really interesting episode for the podcast.
Well, thank you very much. Yes. So this takes me back to the 1970s and a young man with a degree in history and a strong desire to help humanity in some way or other, saw an episode of a TV series that was very popular in those days called Emergency, which showed the work of the Los Angeles Fire Department paramedics. And that got me excited to go and see what they were doing. So I packed my bags, went over to LA, did some ride-alongs with the Beverly Hills Fire Department, which was pretty exciting, and went up to Baltimore and spent some time with their helicopter team up there, the Maryland Institute of EMS, and finally was invited to train as a paramedic in San Francisco. And San Francisco, back in the 1970s, was an interesting place, partly because the emergency services were run by the Department of Public Health, not by the fire department, which meant that because I wasn't a big strapping 6'6" fireman, I could get in to train there, which was a big advantage. But also, San Francisco was just ending the period of flower power. And at that time, there'd been a huge drugs problem, a hippie era problem, and there had been a great need for clinicians to help provide emergency care to a population of people who lived on the street, who had many of the problems of America's inner cities in terms of substance and alcohol misuse problems, and a lot of shootings and stabbings and events like that going on. And so you had this situation in the 1970s that was unique in that you had both supply and demand. The supply was that America was just finishing the Vietnam War, and between sort of the mid-1960s to the mid-1970s, you had a lot of people who had been trained in the military as corpsmen who were coming out of the military very highly trained, very experienced, not just in combat medicine, but also because they were looking after their colleagues. So they were doing minor illness and these kinds of things on their troops, and they were looking after folks in villages in Vietnam, and again, providing a primary healthcare service to them. So you had this group of people who were coming back to the States, and they needed some kind of system to help them transition from the military to civilian practice. And that is why you see the development of the physician assistant program in the mid to late 1960s in America, because you had this supply of people coming from the military. At the same time, you had this demand. America was experiencing a huge epidemic of road accidents. It had substance and alcohol misuse problems. It had a lot of trauma on its inner city battlefields. And so you had this situation of supply and demand. And in San Francisco, you saw that in its entirety, because around the city, there were located and co-located ambulance stations with what we would call walk-in centres or minor illness units. And this is going back now to the 1970s. The Americans had already seen the advantage of using non-physicians to staff care in the community. And that was needed because primary care was not very popular in the States. It didn't pay well. And so doctors tended not to become primary care physicians in those days. And similarly, in rural areas, there was an under-resourcing of doctors. So there you'd got these fantastically trained people, a real need for them to work. And what happened was they put those two together. And that is how physician assistants came about. And so in addition to being a paramedic, that was a secondary role that I had. And it was fantastic because we worked in a downtown emergency room where we saw all the healthcare problems that you would normally see in primary care, but also a fair number of people who couldn't access healthcare in any other means but to go into this walk-in centre.
Fantastic. Thank you, Paul. So from history graduate to paramedic to then physician assistant, as it was in the States in the 70s.
You spent a lot of time really doing primary care type work, but on a population of patients who had no other access to healthcare. So they had no chronic disease care because they didn't have access to insurance. So you tended to see people whose medicine had run out, whose healthcare was not being looked after on a regular basis. So you tended to see many more crises in medicine than you would do over here because of that. The other thing was about 50% of our patient population, their primary problem was alcohol or substance misuse, which had put them on the streets or had put them in sort of difficult circumstances. Even if they did live and rent somewhere, they didn't have health insurance, which meant that their healthcare needs were not met. So you saw a lot of people with very advanced conditions that had not been picked up, but you also saw patients with very unusual advanced conditions like Wernicke-Korsakoff syndrome at a very young age from prolonged alcohol misuse. And you saw a lot of people who came in who you had to sort out. The other thing was that you had to appreciate that they couldn't get healthcare anywhere else. And therefore, you were their sole healthcare provider. So you couldn't sort of say, well, you know, you need to go and see a specialist. You had to deal with a lot of it in-house with the doctors, the emergency medicine doctors who you were working with. At no stage did I refer to myself as a physician assistant. And at no stage did I become a formalized physician assistant. It was very much being trained to work alongside an individual doctor as part of his desire to see someone become trained in delivering primary care, because I'd already said that I was keen to not just provide emergency care, but also to volunteer my time to provide a primary care service to people who I considered needed that care.
Interesting, isn't it, how the physician associate or physician assistant profession at that time was being used in the States to plug a gap, I suppose, in their healthcare system.
I don't think it's fair to say plug a gap. I think what they recognized was that they had a pool of individuals who were very highly skilled and very experienced, who were keen to fulfill the same role that they had worked in for many years within the military, but within a civilian setting. And therefore, you had this situation where you could put these folks to good use. And it was how you went about that that really helped to form the basis of physician assistance in the civilian situation. The fact that they recognized at the same time that there was a role for these people, and that's why I say that it was supply and demand. It wasn't just supply, it wasn't just demand. It was a unique situation where there was a supply and there was also a demand. And enlightened physicians and healthcare systems recognized that they could make great use of this body of individuals to work in particular situations to answer the needs that were there. And since then, it has really gone on leaps and bounds. And I've watched it move from America over here. I can remember the excitement of seeing the first articles appear in the GP magazines, where a couple of PAs came over from America to work in a practice in this country because the single-handed GP at that time couldn't find a partner to come and work in his practice. And so he brought in 2 PAs from the States to work with him. And I can remember feeling so excited that at last this was happening, because I'd always considered that it had such a great potential in this country.
And for any listeners who are interested in hearing from those physician assistants who came over from America in the very early days, I've made an episode with Rachel de Toro, so you can look back on the podcast feed and hear what that experience was like for her coming over as one of the first PAs. Thank you, Paul. I wonder what your thoughts are on in terms of whether that supply and demand is similar to how PAs have been established in the NHS, or whether there are sort of perhaps a disparity between that and the American PAs.
I think that's an interesting question. And it's very much the same when you look at the development of paramedics. So I came back from the States having seen what paramedics can deliver at the roadside and in people's homes. I became what was known then as a registered emergency medical technician paramedic with what was called the National Association of Emergency Medical Technicians. And I set up NAEMT paramedic training courses in Cambridgeshire. And this received, I think it's fair to say, a mixed reception. A mixed reception from the ambulance service, because they weren't quite sure what paramedics were and what to do with them. A mixed reception from doctors, because doctors said, how on earth can ambulance folks deliver that level of care? And it was, again, it took a fair amount of convincing some people that if you trained professionals appropriately, they could deliver care to that standard. But eventually we won the argument. And within a short period of time, the NHS had taken on paramedic training, and the rest is history, because now you've got highly trained critical care paramedics delivering a high standard of emergency care. It took quite a lot longer to persuade folks that paramedics could deliver primary care. And that debate is still ongoing in some areas, because although there is now a formal training program for paramedics to transition into primary care, there is still a certain resistance amongst certain members of the medical profession to allow advanced practitioners and PAs to do their stuff, which they're very capable of doing. And again, it is a function of us getting the word out there, of ensuring that folks are trained properly and are regulated properly. And hopefully that will give doctors the confidence to work more closely with them.
If only everybody was as enlightened.
Although we need to increase the number of clinicians coming into healthcare, we also need to retain them. And I think we're not very good at retaining people. And if you look at what happens in the first 5 years post-qualification, we lose a lot of people because we haven't cared for them properly. I've always said that perhaps what we should do is just stop and take a breath at 5 years and say to people, are you happy? Would you be happier being a PA in primary care than a PA in something else, or vice versa? Or would you rather work part-time in one and part-time in another, so that you join two together? Or what is it exactly that you are unhappy with, that you're struggling with? And if people knew that review was coming up, then they might have a different view of those first 5 years. That there is an opportunity to stop, take a breath, and just say, right, okay, am I happy here? And similarly, in the last 5 years, or perhaps 10 years, we lose a lot of people at that end, because, again, we don't stop and review and say, okay, let's take a review every 5 years or 10 years and actually see how people are, whether they're happy, whether they'd like to do something else, like to do something differently. And this is really part of my sort of thinking about how we develop people over time. That one of the things that I've always felt slightly uncomfortable with in this country is that in America they define a role and then they train you to that role. There is a very strong link between training and role. In this country, they educate you, and they don't necessarily educate you to a particular role. They educate you, and very often that link between education and the role is not connected in the same way as training for a role is. If you see what I mean, you get generic training for that role. So if you're becoming a PA in primary care, you get generic training to become a PA. But then if you want to move into primary care, there is no formal training course for you. You're not prepared to work in primary care. You're not prepared for that role. Nobody has defined what that role is, and therefore you're not trained for that role. Now, in America, that would be very different. You would be trained for that role. Therefore, the role needs to be defined in order for you to be trained. And therefore, if you look at where we are in this country, what you have in primary care is that you have GPs. It's still a very GP-centered model. You have other people around those GPs, so that there are AMPs, ACPs, specialist paramedics, PAs, community pharmacists, physiotherapists, and so on. But each of them is trained separately. Each of them is fulfilling a different role. And there is no integration between the curriculum, and there is no integration between the roles. So that I would rather see a model in which we all were part of one curriculum, when it comes to training, and that we decide who is going to do what, and then we train them for those roles. And we train them in multidisciplinary training programs. So that if you're a paramedic or a nurse or a PA and you're going to be doing minor illness, you all train to the same level. Okay, the training is the same. So if a patient goes to see a GP, a nurse, a PA, a paramedic, they are looked after in the same way, to the same guidelines, to the same standard of care. Okay, I think that's fundamentally important. Then you can add on to those little roles in a modular way so that you make them bigger roles. And at the heart of that, because one of the things that GPs often feel uncomfortable about relinquishing responsibility and relinquishing part of their role is because they don't see that there is another role that they could take on. And if you develop this in a much more integrated and coordinated way, what you could say is, look, let's take the minor illness away from you. Let's not even train you in that. Okay? These folks will do your minor illness. These folks will do your contraception. These folks will do your hypertension clinics and so on and so forth. They're very capable of being trained. We'll train them to do that. Then you can decide when you take someone on what you want them to do. And you can add on modules through to do, if you want them to do something else. But what we're going to do with you, GPs, is we're going to treat you like consultants. So you've got a specialist role here. So we're going to take your training further, a training program to develop that, okay? And that you take this integrated approach so that GPs don't feel threatened that they're losing parts of their work because they're developing something else. And I think that will get round some of the concerns. And then the other concerns, I think, would be dealt with by introducing a training program to which GPSTs or PAs or nurses or whoever can subscribe to, so that if a GPST wants to do minor illness, they can do minor illness and be sitting alongside people who are all following the same guidelines, all receiving the same training.
And I think that would help a lot with the integration of new roles, such as PAs, into the previously GP-only space of primary care. If they knew that our training was sufficient, so that they could trust us to do the roles, that level of trust between PA and GP would come easier, wouldn't it?
Yes. We come back to supply and demand here, James, because at the moment there is a huge demand in primary care for someone to see patients, for someone to look at results, to look at letters, to manage patients in part. If we looked at this in a much more integrated and collaborative way, then everybody would work together, and the GP would have a role that is different from their role now. And yes, it is not the traditional model of continuity of care that an individual has with a patient. But what you're doing is creating continuity within the unit of care, so that, you know, the patient may be seen by a nurse or a PA or whoever who takes them to that GP where it's necessary, and the continuity may be provided not by the GP in the first instance, but by the people around them, in the same way as a consultant's continuity of care is delegated to his juniors working around him. The person you see in the outpatient clinic is not the consultant always, but that junior can take that patient to the consultant. That's the kind of model that I think would work much better than what we have at the moment, which is we need somebody, let's grab someone. So can we get a nurse or a paramedic or a PA without really understanding the differences in the training, the differences in the care that they can provide, the role that they can fulfill within the practice? And I think GPs are just learning these. But equally, they're not sure what you are. They're not sure what your training is. You're not sure what your experience is. They're not sure how they should supervise you and if they should supervise you. And therefore, you're not a GPST, but on the other hand, you're supposed to fulfill part of the role of the GP. So why aren't you given a period of time like GPST with protected time and protected training?
A lot of what you've said rings true for me. I'm coming up for 5 years as a qualified PA working in primary care. I think not having the role defined can lead some physician associates to become quite despondent about the role, to lose their passion for the role. And like you say, for retention of staff at that point, it becomes an issue.
If you start with a curriculum, put everything in it, everybody, so you put every bit of primary care in that role, and then you sit down multi-professionally and you say, right, you're the ideal person to do this, you're the ideal person to do that. What additional training would you need to fulfill that role? So everything is planned. Okay. So you put the same training program on for the multidisciplinary approach to that. And that means that if a patient comes in with a need for a particular service, it doesn't matter who's providing it. They've all been through the same module. The level of care should be the same. But it also allows you to say at 5 years, to have a review and say, okay, in your CPD, in your appraisal, is there anything else you'd like to develop? So you might have a PA who says, I'd really love to develop skills in ultrasound or minor surgery or whatever it is. And the practice says, wow, we never thought of that. You can go on a course or sell services for ultrasound to other practices or whatever model you want. But what it does is everybody then can say, okay, I'd like to, after 5 years, I no longer want to do minor illness. I want to do this. And there is a pathway for every profession, every discipline working in primary care to migrate to that module, do that module, and bring that back to the practice. It shouldn't matter who is doing it. If that program, if that training program is multidisciplinary, it doesn't matter who goes on it. They all come out with the same qualification.
I totally agree. And I think skill mix is really important. Business as usual. I think learning together as different disciplines, learning from each other and with each other.
It then sort of links training and development to training in a much more integrated approach, in a much more patient-centered, service-led approach than we've got at the moment.
Which, as you say, improves service for the patient, but also has the added benefit of improving development for the clinician, job satisfaction, retention.
There's no reason why PAs, nurses, paramedics can't do all of these things, can't deliver all of these services at exactly the same level as a doctor. There's nothing mystical and mythical about having a medical degree. It's about whether you're trained for that role. Okay. And that's the important connection here. Training for a role. And that's why I'm so keen on sort of trying to get somebody to set up a curriculum which contains all the roles, and then people can decide which roles they want delegated to whom. And if they want a healthcare professional to develop a skill in a particular area, there is a place for that individual to go and get trained, regardless of who they are.
Well, we're getting dangerously close to doing workforce planning in primary care.
You can call it workforce planning. It is exactly that. You know, you can see it in other parts of the hospital too. Things that were once the preserve of doctors are now being shared. And that is making doctors' lives better, but it is also making the lives of patients better. It's meaning that people are properly trained for the roles that they have. And that keeps everybody interested in their development.
Paul, thank you so much for joining me on the PA podcast. I really appreciate you giving up the time. I found it fascinating to hear your thoughts, and I agree quite strongly with what you've said. If people have heard our episode, it may have sparked off ideas in their head. They may have questions about what we've spoken about. Are there any resources online, places you would point people to go to? Or if they've got questions, where should they ask them?
I would simply say to them that it is worthwhile exploring the resources on the American Academy of Family Physicians, AAFP website, because again, you will see similar kinds of issues being discussed in the States as there are over here. So there was recently a discussion about whether nurses and PAs and folks should become part of the AAFP, as you probably know. And there was some resistance to that. So it's interesting to compare and contrast that even in a system that's been going much longer than ours, there's still a bit of resistance to developing things. They have some very nice quotes there about integrated and collaborative working and recommendations about how you should try and work together. And I just think it's a good website to just explore.
And that is a topic in my mind, an idea I've had around the integration of physician associates in primary care and the role of things like the Royal College of General Practitioners. And I imagine that will be a similar sort of process and possibly some arguments that might come up. Thank you so much for joining me on the podcast. And thanks to you, the listener, as well, for listening to the podcast. I really appreciate the support that everyone is showing the Physician Associate podcast. I hope you found it a really enjoyable and interesting and informative episode to listen to. If you've got ideas for future episodes of the PA podcast, I would love to hear from you. Why not come on as a guest with me? If you'd like to get in touch with any suggestions, please reach out to me on social media at PA Podcast UK. And I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.